again for taking the time to join us today. We have Dr. George Ford, who is our pediatric endocrinology specialist. And so we'll go ahead and jump right into things in the respective time for you both. How's that sound?
Thanks, guys. And of course, Seth, as I mentioned, I'm working, so if I have to hurry up and cut out, my apologies in advance.
No worries. You do what you got to do. No worries at all.
All right. Well, I guess we'll go ahead and bring up the PowerPoint, but you know, everyone should have received this kind of color-coded protocol for all the emergency rooms in our area. We created kind of a very precise, kind of just one-page summary of the general management of DKA in children. We're hoping that having these laminated copies up and available in EDs in our area will allow it to be implemented and be easily accessible. Let's see. Also, if people are interested while they're bringing up the things, they did recently come out again with consensus guidelines for DKA management. The ISPAD clinical practice consensus guidelines, they're really excellent. We're not going to be able with the time we have to go over all the details, but this is a great article to read. I have no financial interest in DKA. I think most of you kind of probably know these things, but you know, about 1 in 400 children has type 1 diabetes, makes up about 5 to 10% of patients with diabetes, often peaks in puberty, is autoimmune. There's about a 5% risk for siblings, 33% risk for twins that are identical. So I'm just gonna have Seth kind of read just a basic DKA case and kind of discuss that.
All right, so we have a 13-year-old previously healthy Caucasian female who comes to the ED with pretty typical history, right? So a week of polyuria, polydipsia, and vomiting. Family came to the ED due to a decrease in mental status, and there was found to have a glucose of 812, actually discovered at the urgent care. And on further questioning, the parents reported 10-pound weight loss, and there's a family history positive for Hashimoto's. So your initial labs, your pH is 7.1, bicarb on the blood gas is 6.5 with the creat of 2.5. And then on your serum labs, you have a sodium of 128, K of 4.8, chloride's normal at 105, bicarb is very low at 5, creatinine 1, BUN 25, mag 1.1, phos 4.5, and you have large urine ketones and with an A1C of greater than 13. And on her physical exam, she weighs 82 kilos, which is greater than 95th percentile for her age. Blood pressure is 98/44. She has dry mucous membranes, cool hands and feet, delayed cap refill, and she does have an altered mental status. So I guess, Dan, Paul, any thoughts on this case in terms of initial management, initial concerns?
Yes, my couple of things. Initially, her altered mental status, cool hands and feet, delayed capillary refill, and blood pressure all indicate to me that she is in more than moderate dehydration. She's in the hemodynamically unstable.
Sure. Gotcha. I would agree.
Yeah, I agree. We've got to be aggressive with fluid resuscitation, it sounds like.
Yeah. Okay, great. Well, let's kind of go through a couple kind of things and we'll kind of discuss them. Obviously, I think everyone's familiar with the general warning signs of type 1 diabetes. The basic definition obviously is met by this patient. So, you know, in general, kind of just goals of our therapy, usually we're going to want to correct dehydration slowly over 48 hours. We want to correct the acidosis, obviously, and reverse the ketosis, bringing the glucose down slowly. Obviously, identify and treat any precipitating event, and then avoid complications. So this is kind of just general electrolytes and labs, and you can find this in the protocol. And I think most people are familiar with sending these labs. After initial boluses, general good fluid rate for most people is going to be about 1.5. In this case, we might be more aggressive since she appears to be somewhat hemodynamically unstable. So kind of just getting to fluid boluses. So, most patients in DKA are not going to be quite as sick as our case presentation. They're usually going to be more mild to moderate dehydration. In those cases, we do recommend just a 10 cc per kilo bolus given over about 30 minutes, and then avoiding kind of excessive additional bolusing. You can always, of course, reassess the patient to see if you feel another bolus is necessary. But excessive fluid administration is associated with an increased risk of cerebral edema. And we have noticed that when people get flooded with fluids, we've had several cases where they come to us and we're having to give mannitol or 3% normal saline. And I've actually seen that happen more here than I did in the prior 7 years before I came here. So we're trying to work on that. Certainly in this case, with someone who's hemodynamically unstable, you can consider giving a true 20 cc per kilo bolus. One of the things that we find is that people just get flooded, especially the teenagers. Will just get flooded. They'll just give 2 liters, give 3 liters. Sometimes we've seen people get 4 or 5 liters. They just kind of flood them with fluids. So we're trying to get away from that, given the potential risk there. It also potentially drops the blood sugar too quickly to get that much fluid. We do use the 2-bag method. We realize most EDs are not going to be able to do that, so it's kind of more of a PICU portion of the protocol. But in general, we have people just use normal saline after bolusing at 1.5 maintenance, usually non-dextrose containing unless blood sugars are falling to less than 300. In general, we're trying to drop the blood sugar by 50 to 75 an hour. Sometimes it drops more precipitously just with fluid administration. And usually you're going to want to start fluids for the first hour before you would begin treating with IV insulin. And essentially, it's really important to kind of discuss with PICU kind of what would be best in terms of adding dextrose or not to fluids in transport, as well as potentially adding KCl. Any questions on that?
No, sir.
Okay.
George, on the ones where you've seen people coming in with cerebral edema, have you been able to document the fluids that were given ahead before they came to you?
Yes.
Okay.
And we're actually including them, we were randomly including 20 patients who were managed at outside EDs that came to us. But it does include some of those patients who developed cerebral edema, and we have documented that they were given excessive fluid administration.
Okay.
An adult protocol, in general, adults often kind of flood them with fluids, and people just kind of treat children the same way.
Yeah. That makes me concerned for because you mentioned like a 16-year-old, makes me concerned for like a 21, 22-year-old.
Yeah.
In DKA, are we doing the same?
In general, the same principles really ought to apply. I do know that in general, adult protocols are a little more forgiving in terms of fluid administration, but in general, people still are exceeding those protocols as well.
Okay, thank you.
So this is kind of our true false. In the initial presentation, insulin bolus is generally appropriate. True or false?
False.
definitely false, and I would say more than half of the patients that come to NICE-Wanger have been given an insulin bolus, sometimes more than one. That's one of the areas we're trying to improve on, is to avoid insulin bolusing. Again, that's part of the risk for increased morbidity as well as cerebral edema. In general, if you're going to start IV insulin, we recommend starting at about 0.05 units per kilo per hour, and then titrating that up by 0.01 units per kilo per hour. In general, you're going to be between 0.05 and 0.1. If you've got a teenager who weighs more, you could start potentially right at 0.1, especially if you kind of already know their insulin sensitivity. But if they've got a really high blood sugar, it's better to start slow and get that sugar coming down slowly. In this case, we did have someone whose blood sugar is quite high, and so between fluid and insulin, we could make the mistake of dropping that sugar quickly and changing the serum osmolality very quickly, and that again is a risk factor for cerebral edema. So I always tell people slow and steady wins the race. And in these cases, it works much better if we're kind of appropriately less aggressive and then increase as needed. These again are kind of just our basic labs that we'll continue to follow on this patient. I don't think I'm going to spend too much time there because I think most physicians are aware of those. So one of the big things we are trying to avoid is cerebral edema. 20% of patients with clinically evident cerebral edema will die, so about 1 in 5. And then another 1 in 5 will have mild to severe neurological outcomes. So those at risk includes anyone with a pH less than 7.1, a higher BUN, lower PCO2, and a higher K. Certainly if they present with a baseline mental status that's already abnormal. Real high risk patients that are new. So 3 times the risk, especially if they've been 5. Often little kids are missed, especially younger children, just not missed out. And actually, a lot of our morbidity has come from that group.
Let me ask you a question. In your experience, what's the youngest that you've seen a diagnosis of new onset DKA?
13 months.
13 months, yeah. So, and it's probably about 18 months for me. So I think that's another take-home point too, is, we typically don't think about that in those age ranges. But any altered mental status child, even down into that toddler range, a quick point-of-care blood glucose is easy to do, and we see, Dr. Ford and I see a lot of these kids after they've seen 2 or 3 folks prior, maybe a couple urgent cares, maybe to their primary care, before about a 3rd or 4th physician finally picked up on it, just because those kids fell out of the typical age range for new onset DKA and new diagnosis. And so this is, in my mind, for the ED folks, this is one of the biggest pitfalls, is if we know that a new diagnosis plus a new diagnosis at a young age, those are already 2 risk factors for possible fatal cerebral edema. This is just one of the big teaching points that you always have to think outside the box in terms of ages here. So although we don't typically see 2-year-olds with DKA, it absolutely happens, and they are the ones that are at greater risk.
Right. Just before I got there, there was a patient who stroked out that way, and they were 2 years old. So it's something to think about, and for reasons we actually don't understand, there's always an increased incidence of type 1 diabetes every year. Actually, it's usually 2 or 3% more every single year. And for some reason, the age group between 2 and 5 has increased significantly in past years. So we're not sure why that is. Hopefully someday we'll understand what the triggers are and be able to prevent it.
George, can you repeat that part? Did I understand you to say that we see a 2 to 3% increase in prevalence of diabetes in young kids per year?
Well, that 2-3% in all children, but there's been kind of a spike among that 2-3% in kids 2 to 5 years of age. And we're not exactly sure why children are presenting more often early with type 1 diabetes than they have in the past.
So over 20 years, we're going to see a doubling?
Potentially. And in countries that are farther north, the percentage is much higher. So like Finland, for example, 6 to 7%.
Okay.
In general, autoimmune disease goes north. Certainly type 1 fits that better, which is why vitamin D sufficiency is probably protective for patients who are at risk for autoimmune disease. So our next true or false is bicarbonate should be given if pH is less than 7 on initial ECG, or if the patient has signs of cerebral edema.
Really, I mean, I've really moved away from bicarbonate in most situations, and cardiac instability on this protocol says one of the main reasons to give.
Right. So one of the other things that kind of we noted when we were kind of deciding to make this project is that the use of bicarbonate in our region was fairly common, and that it was not rare for us to get a report from an outside facility that a child had been given bicarbonate. So that's one of the reasons we want to talk a little bit more about it. But in general, bicarbonate use is discouraged. It's actually the number one potential increased risk of cerebral edema is the use of bicarb, 4 times the risk if it's been administered. In general, it should be avoided unless there is kind of a combination of very low pH and cardiac instability. And even then, the guidelines don't say it should be given. They just say it should be considered. And again, here's some other kind of, on this slide, you'll see other things we kind of talked about. If you give insulin during that first hour when really we just want fluid administration, that increases our risk. Again, dropping that blood sugar too quickly, which often happens with too much fluid administration, is a risk. Anytime you're maxing out that 50 cc's per kilo in the first 4 hours, that's another big risk factor. And then on labs, if there's persistent hyponatremia, obviously corrected for the blood glucose and or hypernatremia.
So for clarification with the scenario, I realize you will go back to it, tying it into the cerebral edema and rapid rehydration. This patient's hemodynamically unstable, so it wouldn't be unreasonable at all to go ahead and start at least the 20 mils per kg and then reassess, correct?
Correct.
Just making sure I didn't miss that somewhere.
Yeah, no. In this case, we would be a little more aggressive because of her initial presentation, degree of dehydration based on her vital signs and physical exam findings. So yes, but in general, I will say most cases of DKA do not fall in that category. Yet most people generally will receive not 1 but 2 20 cc per kilo boluses, or people just order kind of 2 to 4 liters of fluid to be given. So that's where it gets a little more problematic.
Gotcha.
Yeah.
Treating it more like the adults and giving lots of fluids when they don't really need it.
Exactly.
Right.
And then often giving bicarbonate and very early in therapy, not really actually giving the patients kind of time to kind of follow what they actually do. And in none of the cases of kids who were sent to Niswonger was there any actual biosigns that were abnormal or signs of cardiac instability. It was usually just based on the pH being very low. People seem to be, and older protocols from decades ago did use bicarbonate more. So I think it's not necessarily that people are doing the wrong thing. They just might not be aware of that the guidelines have changed.
Now, I agree with Dan, at least on my end. I typically don't do bicarb. It looks like the newer literature has just gone away from it.
Right. And in general, it should be one of those things that you feel like you've kind of tried all the normal things and things are turning south, and it should be considered in that case.
Thank you.
Yep. So here's just kind of a list of kind of symptoms that can come with cerebral edema. I think, generally, if someone starts treatment and they're developing a headache and it's getting more and more severe, that's concerning. Pretty rare to have seizure. If you've got pretty clinically significant cerebral edema if you're now noticing unexpected bradycardia or pupillary changes. And then the other thing that's a real big tip-off that people sometimes miss is that even though the labs are all heading in the right direction and improving, the patient seems to actually be getting worse, and that should be a tip-off to be worried that they're developing cerebral edema.
And I would have to say, if I had to pick one out of that list, clinically for me, I would go altered mental status. In terms of mannitol or not. That's usually my indicator in the PZD. Especially if you think about your 18-month-old, your 2-year-old, they may be able to tell you whether they have a headache or not. Probably not, right? In cerebral edema, I've seen very few cases of seizures. And then if you think about the actual pathologic process that's going on with the edema, if you're already bradycardic, the horse is kind of out of the barn. If you're bradycardic with pupillary changes. So I would, for my personal practice, the altered mental status is my first soft white flag, so to speak, that things are going down a bad pathway.
Seth, question for you. Altered mental status, for instance, in this case, you hydrate and you start the insulin drip. Are you thinking of starting mannitol early on, even in this one or this case, or would you wait an hour?
I think that's a great question. And I think, one of the big take-home points is frequent reassessment. I mean, this is going to be a patient that we're probably one-to-one with for the first 20 to even more minutes.
Right.
And I think, getting the IV access, seeing where you are hemodynamically, and we all have seen those kids that perk up with some IV fluids very quickly. And if I'm starting those first few steps and I still see a drastic altered mental status change, then I would likely go toward mannitol and having it at least ready to give.
Now, when you say change, are you meaning a deterioration, or are you meaning just no improvement from what her baseline mental status is?
I would probably go more with deterioration, to be honest with you. Every case is going to be a little bit different in that, and I think if you line 10 people up and say, when would you start mannitol, you're going to see a little bit of variation there, but I would go with the change overall.
Yeah, and usually you're gonna notice somewhat, to some degree, an acute change. Often a headache will come on and the patient will complain of a headache that they didn't have at initial presentation, or they'll have been mentating, been a little bit out of it, but then suddenly become, very unresponsive and unable to answer questions. In general, like he was saying, you should be just seeing this general improvement as fluid is administered, IBMs have started. You're seeing a nice, steady improvement in mental status. You usually can hold on. But again, always going to come down to clinical judgment.
In this
the clinical diagnosis, there's no lab to send, and we'll talk about imaging in a second, but it really is one of those things where you're using your judgment. And there is this table to consider and use that people try to come up with in terms of when should you give cerebral edema. The only problem I have with it is that most people, especially initially, are going to meet a lot of those minor criteria. So I feel like it's a little more generous, perhaps in terms, I think we might overtreat. But this is a guideline that came out in 2004 and is still used by some. I really feel like if you're obviously if you're meeting any of those major criteria, kind of that minor criteria is going to take more of the ongoing evaluation to really determine if we think that they need treatment. Was there a question?
I guess I'm thinking that in this case particularly, this gal's altered mental status is more likely due to the dehydration, decreased cerebral perfusion, rather than presenting already with cerebral edema.
Agreed.
Okay. All right.
And in fact, in this particular case, it's a real case. The patient did respond very well to hydration and initial insulin, and did not receive mannitol or 3%.
Okay, that's helpful. Thanks.
So if you do feel like they've reached that point where you feel they're at risk for or likely have cerebral edema, the general guidelines are to reduce the rate of fluid administration by at least a third, raise the head of the bed. You want to avoid intubation if at all possible. It is associated with worse neurological outcomes. I think I've only ever seen 1 or 2 patients with DKA intubated over the last 8 years or so. And then, there are 2 choices, IV mannitol and 3%. And dosages there. It kind of depends a little bit on the preferences of your PICU. 3% has been used more recently than in the past. The guidelines do generally still start, however, with IV mannitol as the first choice, and then consideration for either a repeat dose of mannitol or 3% after that if it did not appear to be effective. In the end, I think it's more that we've identified and begun treatment that's going to matter. Probably not going to matter as much which of the 2 you choose. One thing to just kind of know in terms of kind of the ER, CT and MRI changes are usually not actually seen in early cerebral edema. The newest guidelines from ISPAD actually basically state that unless the patient's 100% stable, they don't recommend any imaging of any kind. Now, obviously, we don't want that patient in a CT room while they're destabilizing. Just kind of looking statistically, initial scans are normal in 40% of cases where cerebral edema is later actually confirmed. So again, the take home is it's not always diagnostic, and certainly if you're worried about cerebral edema, there's really not a reason to get a CT scan while they're in the emergency room. That's kind of the basics. So, just to kind of go over the sheet, hopefully you can see that as well. But the basics we really want people to focus on is making sure they're being very thoughtful about fluid administration, avoid flooding the patient, starting at an IV insulin dose. A lot of people are jumping to 0.1 or 0.2 units per kilo per hour, but all the guidelines start now at 0.05. Unless you have a known diabetic and you can kind of just see from their insulin plan on their pump or their shots that they obviously receive more insulin than that in a 24-hour period. In those cases, you can be more aggressive because you already have a sense of their insulin sensitivity. But even in them, we don't want to drop their blood sugar too quickly. And then, we have great guidelines here in terms of just fluids. I don't know how often you're going to have the 2-bag method available at your facility. But if possible, that is the recommended course. And then, of course, we've got the rest of the guidelines and dosing. and discussion of bicarb. We feel strongly that if we could reduce the use of bicarbonate, excessive fluid, and insulin bolusing in our region, that we would find that we weren't having as many cases where we're giving mannitol for suspected cerebral edema when they present 2 nights longer.
And then the last 2 very quick points is, if you are at a facility and you're thinking about the two bag method, this is an opportunity to really engage your pharmacy team, just to make sure that what you have in your mind and what you're ordering is what makes it, what makes it to the patient. And then obviously the folks at the Nice Longer ED or Nice Longer PICU, in conjunction with the on-call endocrinologist, we're always there to help walk through if there's ever any concern or question. The other point that I just wanted to make very briefly is, if you are in that 1 in a million case where you do have to intubate a DKA patient, I would definitely consult with the intensivist in terms of vent settings, because the last thing you want to do is hypoventilate these patients, and then they develop a respiratory acidosis in addition to the metabolic acidosis that's going along with the DKA. So kind of adding insult to injury there. And I would say that there are some very well-intentioned respiratory therapists that may accidentally underventilate some kids in terms of rate once they're on the ventilator. Usually tidal volume, you shouldn't have any, it's not a lung issue, so 6 to 8 mLs per kilo will be great for tidal volume, but my big focus and concern would be making sure that the rate is appropriate, that almost matches what you would see in a Kussmaul type of a situation. Because if you think about the Kussmaul pattern that we see, I mean, the body's very smart in terms of trying to treat itself, so it's trying to blow off the acidosis. And so it's frequent to see those kids breathing in the 30s, especially if it's a teenager, in the 30s, maybe even pushing 40. So if we intubate that patient for altered mental status, and then we drop them at a rate of 8 or a respiratory rate of 10 or 12, we may actually make the respiratory acidosis worse and ultimately have a poorer outcome. So,
any questions about the protocol?
I think Dan.
Yeah, can you back up to the slide where it talked about intubation? Yep.
This one?
No, the next one.
Oops, sorry.
Right. No, there was one that talked about avoid hyperventilation.
I remember what slide that was on.
I think so, go forward one. Keep going forward, I think. Next one forward.
There it is.
Yeah. I think I'm thinking intubate if necessary. Then it says the big key says avoid hyperventilation. I think in there maybe we should have something that talks about avoiding hypoventilation as well.
It's a good point.
Yeah, that's a good point. Thank you. I appreciate that feedback.
Because I think for inexperienced people, they may look at that and say, well, let me ventilate about a breath every 10 seconds.
Mm-hmm. Mm-hmm. No, that's a very good point.
No, that's an excellent point, actually. And it's also kind of interesting to think about in terms of our guidelines or future things we'd include on our guidelines, but we actually really don't address intubation in this clinical pathway, although it's addressed somewhat here, minimally, on my slide. So I appreciate that feedback. That's very useful.
Yeah, that's a great point. All right, gentlemen. Thank you so much. Any other questions as we close?
Thank you guys for the presentation and the algorithm information. Appreciate it.
No worries. We appreciate you both. And if you don't mind, kind of spread the word. We do have another scenario, the exact same case, but another showing, so to speak, on December 12th. and I'm sorry, at 8 a.m. Correct, December 12th at 8 a.m. And then this should be available from recorded. It's recorded, so it should be able to.
I saw an archives section on the Echo. Is that where that will be able to be found?
Yes, that's correct. That is correct. So make sure, if you don't mind, to help us spread the word. And again, thank you so much. And we apologize for the technology glitch at the first few minutes, but thanks for taking the time.
Now, will the PowerPoint also be available on the archives?
Yes.
Okay, great. Thank you all very much.
Yeah, thank you for your time.
Thanks, Paul. Thanks, Dan. Have a good day.
It was helpful.
Hey, bye-bye.
All right, see you.
Stop calling me. I'm in the middle of a presentation. No, my wife.
She can call.